start of this. So joining you over from the VA, good to see you all. If you want to come over there, please let me know. I know you all love CPRS so much. So we will go ahead and get started. So our expert today is Dr. Janet Lee from the Division of Pulmonology. And so as way of introduction, Dr. Lee is the chief of the Division of Pulmonary and Critical Care Medicine, the Selma and Herman Seldin Distinguished Professor of Medicine, Professor of Pathology and Immunology. And you can see the educational credentials here. I did want to point out, has an immense amount of honors and awards. If I were to take a screenshot of all of them, this slideshow would have been about 100 slides. But my hand got sore from scrolling, and so I just put that screenshot there. But clearly, well-accomplished faculty member that is joining us today. So if I may bring you up to kind of talk a little bit more. Our one-liner is a 37-year-old gentleman with a history of ischemic systolic heart failure, presenting with one-day duration of shortness of breath. And so our first question to you is, how do you, kind of, what's your initial impression and approach to this?
Well, thank you very much. That one-liner was very helpful. All I can say from that one-liner is the patient is quite young, has heart disease, ischemic systolic heart failure. So I'm thinking probably something possibly related to heart, although I am a pulmonary critical care physician. So my guess is that it would probably be non-cardiac, but anyways, that is actually a salient piece of information. And then a duration of shortness of breath, 1 day. So when I think about shortness of breath, I first think about, the temporal spatial component of it. So the kinetics, is it acute on chronic, subacute, or chronic? And he's already told me that it's acute. Then that means I want to know, is it life-threatening? And typically, I'd like to see the patient, maybe 30 seconds to a minute. You get a really good sense of whether or not this is imminently life-threatening. Are they in respiratory distress? Do they have stridor? Are they completely, obtunded? All of those things are very helpful. But I think about the big three: airway, breathing, and circulation. And then that kind of helps me with sort of narrowing down the broad differential. And that's more the spatial or compartmentalizing where the origins of the shortness of breath. So the initial thought is, I think about cardiac because of this man has ischemic systolic heart failure. So I think, could this be an acute coronary syndrome? Is it pulmonary edema, heart failure? Could it be a tamponade or arrhythmia, or maybe like an intracardiac shunt? Pulmonary is, I think about, airways. Is it supraglottic or upper airway or lower airway disease or obstruction? Or is it parenchymal, pneumonia, airspace disease that can cause, lung injury? Or is it a compressive atelectasis or affecting the pleura, pleural disease, or vascular pulmonary embolus, shunt, a pneumothorax? All of those I kind of think of in consideration. And then other things like metabolic, acidosis, anemia, poisonings, neuromuscular, CNS, and then systemic, renal failure, cirrhosis, and then anaphylaxis, angioedema could also give you dyspnea. So those are kind of my initial thoughts, very broad. And then I probably would like to have a little bit more context. History, HPI would be helpful.
Yeah, I admittedly did not give you a lot. But it is not acute on chronic heart failure. That much I can assure you.
Oh, good.
That would be pretty funny though. All right, so going into our HPI, so we're going to get a little bit more information here. So this patient was in their usual state of health until about a month ago. At that time, developed some intermittent dull right upper quadrant pain and maybe had some shortness of breath associated with the pain. Feels like activity has been limited. Additionally, notes joint pain in the elbows and knees. Symptoms appear to be worse in the morning. In the night prior to the presentation, the patient overnight awoke from sleep and coughed up a small amount of blood. and was experiencing shortness of breath and dull left-sided, non-reproducible, non-positional chest pain. And then also notes he had post-tussive emesis with an episode of coughing, and then has had myalgias that are particularly worse in the legs. And he notes this hyperpigmented, vague, circular, patchy, non-erythematous rash with scaling on the dorsum of bilateral feet and ankles.
Wow, that's a pretty good history. Whoever took that was
So
very
this was one of our former residents,
Oh,
actually,
really?
who, yeah, is phenomenal.
So that's very helpful. This patient had sort of a subacute process going on, about a month in duration. Sounds like he started off with kind of dull right upper quadrant pain and shortness of breath during the pain, and then limited activity. So, you know, the right upper quadrant pain, it's a little bit unclear. Is that the liver? Is it gallbladder? But then the shortness of breath during the pain is this sort of referred pain. It's a little hard to know right now, but then he has joint pain in the elbows and knees, and the symptoms are worse in the morning. And then hemoptysis. He has a little bit of hemoptysis, and this is the day before, or the night prior, and then also experience shortness of breath and chest pain. So a lot of things could be occurring here, and then had post-tussive emesis and myalgias worse in the legs, and then rash. So it sounds like it's probably something systemic. That's one thing, and it's been going on subacute in process. And then the hemoptysis is kind of unusual. Maybe it's some kind of rheumatologic, autoimmune. I could, you know, sort of conceive that based upon sort of a very systemic HPI. But I think I might need a little bit more than the HPI, either the physical exam or review of systems. Would that be?
Yeah, we will get there in a sec. I do want to ask you, you know, when you hear patients talking about coughing up like red tinged sputum or a little bit of blood, what your next follow-up questions are. Because I always hear things like, I coughed up a teaspoon of blood. I'm a terrible baker, so that means nothing to me. Like, what is your next actual set of questions to help you figure out, is this real blood and like a concern or not so much?
So it's the quantity amount, you know, it sounds like it's small, you know, because I usually think of like massive, submassive, or just, you know, hemoptysis of small amount. Is this something that's been going on? It sounds like it's actually rather acute. So I think about, you know, it could be pulmonary embolism, pulmonary infarction. It could also be, I don't know what his like smoking history is, things like that, but I would worry about things like a lung mass or a lung tumor that could cause, you know, hemoptysis, or even like bronchitis, bronchiectasis, an infection could also cause hemoptysis. So I think those are the things that I would think about. The other thing is vasculitis could also cause hemoptysis, like ANCA positive vasculitis, like GPA. People can present with hemoptysis. So those are sort of what I would think about. Infection, obviously.
Yeah. Okay, very helpful. So we'll get a little bit more information. So his medical history, he was diagnosed with ischemic HFrEF about a year ago, also had a PE about a year ago. Doesn't have any surgical history, family history listed here. And then we see his medication. So on a little bit of GDMT for his heart failure, and then is otherwise managed with both an antiplatelet and an anticoagulant. And then our social history has a 7-pack-year history, not a current smoker anymore, and then no alcohol and no other drugs.
Okay. So he has a fairly minimal history of smoking, but he does have a history of pulmonary embolism and ischemic heart, like HFrEF, for a 37-year-old. He's not a well man, it's clear. And I think the fact that he's on aspirin and Pixaban makes me worried. Well, maybe he's got some inflammation, and then being on an anticoagulant could cause that. So it still is a fairly broad differential. It could also be infection. It could be a vasculitis or rheumatologic process. So I think I might need a little bit more information here.
So going through a review of systems. So he reports fatigue, malaise, no fevers, denies runny nose, epistaxis, vision changes. has the shortness of breath and this recent acute hemoptysis, the left-sided dull chest pain, this vague kind of month-long right upper quadrant pain. He noted one episode of diarrhea, but it didn't seem to really carry on from there. And then the myalgias and the joint pain that we discussed, as well as this, faint rash on both really kind of the ankle, dorsal surface of the feet. So with that, any additional thoughts? Next will be our physical exam and objective findings.
Yeah, so he has actually, the joint pain and the myalgias and fatigue. That's very interesting. And I think I would probably think about sort of rheumatologic, possibly vasculitis. And that rash is a little bit interesting as well. So I'd like to know a little bit more about the rash, and maybe his physical examination would be quite helpful.
Yeah. So the physical, interestingly, isn't particularly marked. He's breathing 98% on room air, not in respiratory distress. He is tachycardic and his blood pressure is elevated. But outside of that, not a significant number of positive findings. The rash was just kind of noted to be a small circular scaly rash on the surface of both feet. I don't have any photos of that, but it sort of came across from the history as just being xerosis in that area and perhaps had been there for some time. It wasn't erythematous or anything like that. And so at this point, what is your initial approach? We'll have initial labs coming up here, but are you, seeing this more worried, less worried?
Well, first of all, I think, when I think about somebody who's short of breath, looking at the vital signs, it is a little bit reassuring that this is not imminently life-threatening. I think the blood pressure being on the higher side, I don't know what the heart rate, his normal heart rate is, but I typically use like a shock index just to see what, where they are. 'Cause sometimes you can sort of miss shock that way. And then the fact that he looks like he's not in distress, he's not in stridor, he's not having problems with his breathing is quite reassuring.
Yeah.
So I think that makes me think other things, kind of rule out things like a large pneumothorax or like anaphylaxis, all of those things.
Yeah.
Now I think we would probably need a chest x-ray or some imaging modality in addition to labs. I think the labs would also be helpful because he had a lot of systemic kind of complaints, which makes you think, maybe there's some, a vasculitis, rheumatologic process going on, maybe even, autoimmune process that could be affecting his lungs or maybe his heart. And then that right upper quadrant pain and his GI symptoms, I haven't quite put that together, and I'm hoping that maybe the labs would be more helpful or informative.
Yeah, absolutely. And one thing I do want to mention, so he has this tachycardia. His respiratory rate was actually charted to go higher than that. So his sequential kind of vital signs over the next couple of hours while this patient was in the ED and actively being admitted went up to like 27. And I think what caught my eye here was when it's charted at not 18, it always catches my eye. And so the fact that it was 23, suggested that he was a little bit short of breath potentially.
Okay.
And it quickly was charted at like 27, 28, and then 30 while he was in the ED.
Oh, okay. Well, then that's helpful. That's very helpful.
And then we'll go through our initial lab. So can you tell us a little bit about how you interpret these?
Okay, so his chemistries, for the most part, look okay. The creatinine is 1.2, the BUN is 12, but his, in red, his bicarb is 20. So that's actually helpful. It's, kind of on the lower end of, sort of where I would probably think, maybe there is something going on with his metabolic state right now. Total bilirubin is elevated and he's got transaminitis. It's a little hard to sort of put that together currently, but he has a white count that's 16,000 and he is anemic, and he does have is that an absolute neutrophil count?
Yeah.
Okay. So in what, per cubic mil?
Yeah, so of the 16.4, 14.6.
Oh, okay. All right, sorry.
Yep. And then his MCV, he's very microcytic.
Yeah. Okay, so.
And then his creatinine BUN, these are relatively baseline. And then we'll learn more a little bit after that. So from here, what additional diagnostics would you prefer most? And here are sort of the options.
Well, I would like an imaging.
Imaging. What would you start with?
I think a chest X-ray would be very helpful. I also think, did he get an ABG if you were saying that he was tachypnic? No other labs that he had like a urinalysis?
We have a urine analysis.
Okay.
Yep. So I can give you the UA right away. Oh, we'll get back here.
Oh, okay.
So here's chest X-ray. We'll start with that and then I can give you the urine analysis.
Okay, so this is actually very helpful. It's a portable chest X-ray. I would say that he has, just going through his sort of airways and his parenchymal, he's definitely has bilateral diffuse parenchymal. It looks like airspace disease. His cardiothoracic ratio is, I think, okay. Typically, it's, less than, it's kind of on the border of on the higher side. So the CT ratio, usually greater than 0.5, but on a PA, that might be generous. And then, if I think about, say, somebody who has systolic heart failure, I do think about obviously, is this like pulmonary edema? This doesn't look typically like pulmonary edema. It's a little bit more asymmetric, and it has this confluence of airspace disease on that left side, more like a pneumonia or some kind of other airspace filling process. Typically, I would see more cephalization. Usually, if it was simply the sort of the pedicle width is usually a little bit wider, and this one, it's hard to say this is just simply pulmonary edema, although I can see the fissure. There's a little bit of sort of enhancement of the fissure, and then he's got bilateral airspace disease. He actually doesn't have much in the way of pleural effusions, maybe a slight blunting of that right costophrenic angle. But for the most part, I would be a little bit more concerned about non-cardiac sort of airspace disease, pneumonia, obviously, or maybe some airspace filling process, but I haven't completely ruled out pulmonary edema. You also did say on his exam, he wasn't like edematous. He was really, it was kind of not.
Yeah, no peripheral edema or anything, or elevated JVP noted.
Okay.
So this was the read of the chest X-ray.
Okay. Moderate to severe asymmetric pulmonary edema or multifocal pneumonia. Okay.
And then for our urine studies.
Okay, so he's got 2+ protein and 1+ blood, and he's got some red cells and a little bit of white cells and protein. So it could be, an active process. And do you know if he had any like ANCA or ANA or SED rate or some
We have some of that stuff
you
for you.
do have some of that, because then I'd be thinking about maybe an
It's cooking in the lab though right now.
Yeah, I would be thinking about an airspace filling process as well in the differential. They're kind of rare, but GPA, like an ANCA vasculitis, also anti-GBM disease can cause like a diffuse airspace filling process. Usually they come out really hypoxic. They usually have some kind of history of injury or big time smokers. That's kind of what I've seen with anti-GBM disease. And then lupus. Lupus can cause sort of airspace filling process, like a diffuse alveolar hemorrhage as well. So those are the three vasculitides that I've seen with like a diffuse airspace process.
Yeah.
But it could also be other vasculitides.
So I do want to ask briefly, before we go to the next step of the workup, in this patient, when you see them in the ED and then you see that chest X-ray and those initial labs with that low bicarb, are you, looking for an ABG to help characterize, is this, a respiratory alkalosis with compensation, or is there an acidotic process? Are you always going to reach for an ABG in that standpoint?
Well, not necessarily. I think an ABG is extremely helpful to see really high how hypoxic he is, but he was like 98% SpO2. So I figured, he's probably not super hypoxic. The other thing that's very helpful about an ABG is the AA gradient, because that actually helps you sort of pinpoint the origin of the hypoxemia. But I didn't get the sense he was like very hypoxic. You said he had some respiratory, maybe some mild tachypnea, and he definitely has bilateral airspace disease. So, if you had an ABG, that would be great, because if he had an elevated AA gradient, it would make me think more like it's affecting the alveolar capillary unit. So, the 5 causes of hypoxemia is, high altitude, which he's not. 2 is hypoventilation. The 3rd is shunt, diffusion, and VQ mismatch. So I would think that that would be helpful in that setting. I don't think that that would be necessary, but if I was seeing him in the ER and kind of working him up, certainly things being more common, infection would definitely be up there, and I would be getting blood cultures. I would be making sure if he's making, sputum, get cultures from that. Probably a CT scan would be very helpful just to see the process of that airspace disease. And then I, obviously start antibiotics right away, that type of thing.
Yeah, so we mentioned a number of tests. Where would you like to go next in some of those tests that you've mentioned?
I think a CT scan would be very helpful, but I don't know what you mean by infectious evaluation. Are you thinking like sort of, would you be able to give me like PCRs and blood cultures and things like that?
I think we can do that. Is that what you'd like to see next?
Thank you very much.
Yeah.
Okay, so RVP is, so everything is negative thus far. It doesn't rule out infection, but at least it'll rule out maybe the more common things, viral, the ones that are being checked, and some bacterial pneumonias, and then the blood cultures are negative. So, okay, that's helpful. And then hepatitis B is negative, so that's also helpful too.
All right, and so we'll go to our CT imaging, and for that, I'm going to bring up Dr. Semenkovich to come and talk about the CT findings, which are very subtle.
Oh, my goodness.
This is a ground glass pattern because you can see vessels throughout them. You can see that the distribution involves all words, both ones. Compartment negative, there was nothing in the airway at all. One thing we always worry about here, if somebody has a big month, is obviously bronchitis, but it's just we didn't see anything like that, no masses. Obviously, there wasn't a pneumo. You didn't see one on the chest film. So none of the easy things. I didn't show you the mediastinal windows, but there was no clot. There were no vessel abnormalities. So this is a ground glass pattern. One thing about radiology is you got to know the pattern, and then you got to remember, is there a name sign? And then you got to remember, do you know what the name sign even refers to? Because sometimes I have to look up, like, what is a cottage love sign? And I bake a lot of bread, and that's like diaphragmatic hernia, in case you're interested. So sadly, this is a crazy paving pattern. I had to look up crazy paving when I first heard it. And crazy paving refers to, as you would have guessed, why stones. So at first, when this was described, people thought it was very specific for pulmonary alveolar proteinosis. But unfortunately, like many things in medicine, the more you look, the more you see a zillion causes. I took this out of Radiopedia. I don't know where they were practicing, but of the less common things, we see these here all the time, like virtually every single one of them. And so crazy paving, could be infectious, but obviously there's a huge number of things. The one I would remind you to never forget about is mucinous adeno. So when I see somebody come in with airspace opacities as an outpatient, I always want to follow up to make sure it clears so that we don't see that. Not less common here, we see it all the time. there was a tiny pericardial effusion, but certainly not enough to cause tamponade or shortness of breath. And there really were no other pertinent findings.
Would you be able to, on the CT, point out to us, what are the parts of the lung anatomically that make up kind of those stones that we refer to in the context of crazy paving? Because I hear ground glass and it just has never stuck for me.
The most important thing about ground glass, and it may be hard on the screen, is can you see vessels through it?
Okay.
So, it's not to the level of complete consolidation where you can't see any vessels. But here you can see vessels through, and it's just very non-specific for alveolar filling. And you can see there's a huge number of infections that can do it too. That, not uncommon with vasculitis, pulmonary hemorrhage. I mean, commonly we see it with pulmonary edema. But the septal line should be smooth. So if the septal lines are nodular and you're seeing this, then you're worried about something like lymphangitic spread.
And it's the septal lines of those lung units that are making up kind of the stones that we refer to in crazy
Yeah,
paving.
so you're talking about secondary lobules, which I'm so glad Janice is here because I love secondary lobules. And that's sort of like the radiographic unit, the smallest unit that's marginated by connective tissue. That you can see on a CT scan. And actually the secondary lobule is anatomically have a bronchiole that goes in, and it's followed by a pulmonary artery. And then that's sort of the central lobular area, the parenchyma. And then it's marginated by sort of the vein and lymphatics. So what Dr. Semenkovich is talking about when she says it has to be smooth, a smooth septal sort of thickening, you think about things like edema or, hemorrhage, but also you could have infiltrative disease like, sarcoidosis or lymphangitic spread, but more kind of nodular, you would worry about lymphangitic infiltration and also like lymphocytic interstitial pneumonia. You could also see anything like maybe some of the interstitial lung disease process could affect the interlobular septal. That's what's being enhanced in that crazy paving appearance that you see. The other one that is a great mimicker is PJP can also look like this. It's just kind of an airspace filling process. And then you have some of that interlobular septal enhancement that gives that very distinct process.
Back in the day when I trained, we saw it all the time. And so if you saw this, you would just think of that. One pertinent negative of that is they virtually never have a pleural effusion with PJP. So if you see somebody that supposedly has PJP with a pleural effusion, it's either not PJP or it's PJP plus something else. But
yeah, so those. So it's the interstitium between the secondary lobule units.
Yeah, so they
enhanced.
Surround the secondary lobule, and that is what you're seeing that's enhanced. The lobular unit is sort of probably the smallest unit that's visible, that's marginated by connective tissue. You've also heard of a term called like a sinus. Acinar unit, and that's smaller within the lobules. You'll have many of them, anywhere from 4 to 24, and that is actually where sort of like terminal bronchioles, respiratory bronchioles. So the end of the conducting airways is the terminal bronchioles, and so after that, that's where the acinar unit is the functional unit where is the gas exchange. So, but the lobules are the ones that you can see radiographically. And that's how, when she talks about the sort of all the differential diagnosis, they really look at the lobular sort of unit, and then central lobular emphysema or bronchiolitis, you'll hear them talk about.
Awesome.
Yeah.
So in light of this, how does that sort of alter what your next step is and And has it changed, in terms of prioritizing your differential?
Well, I think infection is definitely still up there, and I would definitely treat him for infection, at least for community-acquired pneumonia, because you can get multifocal pneumonia. I didn't get the sense he has ARDS. ARDS is kind of syndromic and many causes. Most common is actually infection, 67% globally. So I think I would definitely treat him for that, but I would also sort of further evaluate for sort of vasculitis, for other sort of less common things, just to make sure, because clearly it would change your management. He's not immunocompromised, right? I didn't get the sense that
Yeah.
he has like a, okay,
Correct.
so that's actually helpful too.
So we can move to our rheumatologic workup. We've talked about a
Okay.
number of things. So what are the main things you're ordering in your rheumatologic workup, given the findings?
Well, I think an ANA, an ANCA, I think an anti-GBM would be very helpful. Those three are the ones that I think about when and then, alveolar proteinosis, we should probably think about that. So there's an antibody that attacks the GM-CSF. So GM-CSF is granulocyte, monocyte colony stimulating factor. Actually, that's something that has been shown, like if you knock it out in a mouse, and I'm sorry, I'm going into a mouse, but they get proteinosis, and it's because the macrophages are really required to sort of clear up the surfactant that's made by type 2 epithelial cells, which are the progenitor cells that line the alveoli. And so the macrophages, if they don't have GM-CSF, they can't clear surfactant very well. And so people can get it either like primary alveolar proteinosis or a secondary alveolar proteinosis. And secondary is like, due to infection, people who have leukemia, usually like acute myelogenous leukemia, pre-leukemic, and then people who have obviously made antibodies to GM-CSF. So those are probably the ones I would think about.
Yeah. So here's our
okay.
rheumatologic workup.
All
And
right.
GCSF was not sent. But what
anti-GM-CSF.
Yeah, so anti-GM-CSF.
That's okay, because it's very rare.
Yeah.
So ANCA negative, ANA negative, anti-smooth muscle antibody positive. So maybe like some kind of myositis type of picture, which is kind of interesting.
Yeah,
to me.
PK was normal.
Oh, okay.
Yep.
Right.
So our creatine kinase was normal, and then our inflammatory markers are markedly elevated.
Okay. All right. It's some kind of rheumatologic process.
Yeah.
I think there's a number of other antigens that have been identified, and I don't know the whole entire list of them, but the anti-smooth muscle antibody, I'm not sure if that's something that I would see a lot in this type of like diffuse sort of multifocal kind of crazy paving pattern. But do you have any additional
No,
rheumatologic?
this is the bulk of our rheumatologic workup, and
Okay.
for what it's worth, the anti-smooth muscle, it's a very low level for positivity and what they
Okay.
consider.
Okay.
And so for next steps, at what point I'll give you our cardiology workup. NT-pro, not totally unexpectedly elevated, but not in a crazy manner. Our prior left heart cath, he had a CTO of his LAD, so he was never actually intervened on. And then we have our last echo findings here. So, at this point, the team was considering a primary pulmonary process or more systemic process. At what point in this patient, they covered him for infection?
I would bronch.
You would bronch? Okay.
Oh, yeah, definitely.
So we do have bronchoscopy.
You do?
Yeah,
Okay,
yeah.
very good.
Went in there myself.
Okay. A biopsy was okay. The increased bloody return with sequential washings. So diffuse alveolar hemorrhage is what I would say would be in the differential there. Increased bloody return with sequential washings.
Yes. So at what point, I guess I have two questions. At what point do you consider in a patient like this doing a bronch, and how quickly would you jump to that as the next step for workup? And then the second thing, can you tell us a little bit more about what you're looking for on the bronch, given what you saw in the CT? What you would have expected when you went in there?
So, I think the first question was what? When would you?
When would you
want-
choose to do a bronch?
Well, you have sort of the radiograph, you don't have a diagnosis, you have this concern of a vasculitis, you're not treating that, I bronch, right?
Yeah.
That definitely. And then this is actually sort of the description for diffuse alveolar hemorrhage. It's not well characterized, like we actually do cell counts now to see whether or not, because any small amount of hemoglobin is going to make things look red. But I think, the fact that it gets redder and redder is what you're saying is coming from the air spaces. So again, I would have thought it's like either an ANCA negative, diffuse alveolar hemorrhage, vasculitis, ANA, lupus, anti-GBM disease is the three, and then lupus, pneumonitis. Those are the ones that I classically think about. And then you can think of other things like sort of more immune mediated type of stuff. But I still think those are definitely on the differential and more common to cause it than other like scleroderma lung or, sort of mixed connective tissue diseases, although they could have that as well.
Yeah.
And then and sarcoid, typically not, but it was along the bronchovascular bundle. So I think, oh, thank you, Dr. Semenkovich. So
It's still good because my interpretation of lung imaging is good or bad. So this is helpful.
Okay.
So we do have a biopsy as well, and I'll
Okay.
show you the results of that biopsy. So this was many years ago, so I don't have the actual slides,
so
but
pulmonary capillary. Okay.
and so that was what was commented. So in light of this biopsy, we've sort of covered a majority of our workup. What would you consider sort of to be your final labeling diagnosis if you had to choose one?
I would probably like a small vessel vasculitis. Is it like a Pianka? Or there's, I think that's Pianka. Is that what it's called? Or Cianca? Cianca, I think is the one. Can I have a rheumatologist out there that I can phone? But
You already said it in light of our negative. Yeah. So in light of our negative results, the final diagnosis was DAH due to seronegative ANCA-associated vasculitis.
Oh, okay. All right. Okay.
So
Thank you so much.
Yeah, of course, you were right on top of it with it certainly had a systemic, features. And I think that pointed the team in the direction of looking at rheumatologic processes in terms of a hospital course. So I actually combined two hospitalizations here. So his initial hospitalization, he had very mild, he basically had an ACS event. 2 months later presented with some mild hemoptysis, but it wasn't this overt. And at that point, he got the bronch, got the biopsy, and received a diagnosis of ANCA negative or ANCA-associated vasculitis. And then he was started on steroids and Ritux, responded very well, but due to insurance issues, was off of therapy at the time he presented with DAH. And so during this hospitalization with the DAH, he already carried the diagnosis of ANCA-associated vasculitis that was ANCA negative, which was at least fortunate in terms of being able to immediately restart treatment and again, responding very well. What's curious with his early ACS is there is some thought, and I think we're finding out more and more that the coronaries can be involved. They are medium vessels, but there's so much overlap in all of these ANCA-associated vasculitides that they can affect, any vessel in the body. And in particular, we're starting to recognize more and more that they can cause damage to the coronaries. And so it's thought that his coronary disease is actually related to his underlying rheumatologic process. In terms of sort of some teaching points that I took away, vasculitis already not hard enough, so now there's ANCA negative, associated vasculitis here. Turns out up to 30% of individuals have this. In talking to Dr. Diffie, learned an interesting piece that a lot of these patients actually have, they'll be ANCA negative, but they actually have the antibodies. It's just that they're in the tissue and or bound to antigen within the blood. And so it's hard to actually isolate these antibodies. So I also would highly recommend the vasculitis chapter in Harrison's. It's the only chapter in Harrison's I will recommend you read, but it's incredibly useful. And they talk a little bit about the pathology. And one of the curious things about ANCA is it's still very highly debated as to, we know they're necrotizing in some cases or granulomatous in the case of GPA, but the actual antibodies themselves seem to be potentially pathogenic, but not always. There's different mirroring models. So I believe it's in, the C-ANCA antibodies you can put into a mouse and they'll actually get vasculitis, but the P-ANCA, that won't happen. So there's still a lot of debate as to the actual underlying pathophysiologic processes here. Rheumatoid factor antibody is quite common in ANCA vasculitis in general. And so that was a clue here for the team that he had ANCA negative, ANCA associated vasculitis, the fact that he did have a positive rheumatoid factor. And then in terms of takeaways for residents, when you see constitutional symptoms and systemic processes, along with joint, lung, renal, home findings of any degree, think about vasculitis and systemic processes. Quick point on DAH, there's different causes. There's bland hemorrhage. And then in this case, we have pulmonary capillaritis. It's based on biopsy and what the underlying etiology is. So, this person could have just as well had floor heart failure exacerbation and had DAH related to bland hemorrhage if he had significantly elevated left-sided pressures. But here we have a true primary inflammatory cause at the level of those capillaries. And then we, covered the broad differentials. So you think about rheumatologic processes, but also infection and drugs.
Great. Thank you so much.
All
I
right.
learned so much.
Thank you so much.